Welcome to another deep dive from Optic Surgeon, the ophthalmology podcast. Today, we're tackling something almost every patient mentions at some point, floaters.
That's right.
We're going to unpack these, often misunderstood visual things from the basics right through to the critical red flags you absolutely need to know, especially for clinical practice and, of course, your exams.
Yeah, it's such a common complaint, and it really spans a huge range, doesn't it? From totally benign, just age-related changes, all the way to really urgent, sight-threatening conditions. Our mission today really is to give you a clear, concise way to think about them, helping you quickly spot what matters most and, crucially, what needs immediate action.
Okay, let's start with a case,
Yeah.
something you might genuinely see next week on rotation. Imagine this. A 60-year-old patient walks into your clinic. They're reporting a sudden onset of cobwebs. Not just one or two, like a shower of them drifting across their vision.
Sudden onset.
Exactly. And they also mention flashing lights in one eye. Plus, they feel their vision is just a bit blurred.
Okay, that combination, that presentation should immediately set off some alarm bells, right? The key question for you as the clinician seeing them is, what's the very first thing that jumps into your mind? And maybe more importantly, why is acting fast here just so vital?
Right. It's a classic set of symptoms.
It really is, and it carries potentially serious implications.
Okay, let's unpack this then. We keep saying floaters. What exactly are they, fundamentally?
Well, at their core, floaters, the fancy term is muscae volitantes. They're basically mobile opacities, little bits floating around inside the vitreous humor.
That's the gel filling the back of the eye.
Exactly. And these little opacities, they cast shadows on the retina. That's what the patient actually sees. They perceive them as black or gray dots, maybe rings, strands, sometimes even described as spider-like shapes.
And why do they seem to move around, sort of drift, even when the eye is still?
Because they're literally suspended in that vitreous gel. So they move with eye movements, but then they kind of continue to float or settle even after the eye stops moving. You'll notice them most, or patients will, against bright uniform backgrounds. Think a clear blue sky, a white wall, even a computer screen.
Okay. And it's important you mentioned to distinguish these from fixed spots.
Yes, absolutely crucial. These floaters are mobile shadows. Static spots, ones that don't move when the eye moves, could indicate actual blind spot scotomas from retinal problems or even neurological issues. That's a loss of visual field, not just something floating in the field. Big difference.
Got it. So that's the basic definition. Now, thinking about our patient, and really any patient presenting with floaters, what's the full spectrum of symptoms and signs we should be looking out for?
Well, symptom-wise, it varies a lot. It could be that sudden onset of new floaters, like in the case, or maybe just an increase in ones they already had. Then there are those flashing lights, we call them photopsias, often described in the periphery, the temporal field. Patients might also report blurred vision, actual blind spots or scotomas, maybe poor night vision, nyctalopia, or even changes in color vision, dyschromatopsia, sometimes just general discomfort, itching, redness.
And what signs are we actually looking for on examination? What might we see?
Objectively, well, you might see the vitreous opacities themselves on a slit lamp exam, especially with the right lighting and focus. And critically, a dilated fundus exam is key. You could find retinal tears, maybe hemorrhage, or signs of inflammation cells or flare in the vitreous. Those are the visible clues of inflammation inside the eye.
But sometimes the exam is normal.
Yes, and that's a really important point. In many benign cases, like a simple PVD without complications, the examination might be completely normal, and finding that normal is actually a crucial piece of information. It's reassuring.
Right. So the significance ranges hugely. Benign age stuff on one end
Exactly, like age-related vitreous degeneration.
to genuine emergencies on the other.
Yeah.
Like retinal detachment, uveitis, significant hemorrhage.
Precisely. And that's why, and this is key for everyone listening, you cannot dismiss sudden floaters, especially if they come with photopsias. They demand urgent evaluation, period.
Okay. Which brings us back to our 60-year-old patient. The sudden onset, the shower of floaters, those flashing lights.
That combination, yeah, it's not just common, it's a classic red flag. It's screaming for attention, basically.
So let's dig into the why. What actually causes these floaters to appear in the first place? What are the mechanisms?
Broadly speaking, floaters come from opacities within the vitreous itself. That's the main source. But sometimes they're perceived disturbances that actually stem from problems with the retina or even the anterior part of the eye, which then indirectly affect the vitreous or how the retina functions.
Okay.
So for the vitreous opacities themselves, most are caused by changes in the vitreous collagen as it liquefies with age, Or they can be actual cells floating around, inflammatory cells, red blood cells, even glial cells. All of these can cast shadows.
And the flashes, the photopsias, where do they come from?
Ugh. The flashes are fascinating. They usually result from direct physical stimulation of the retina, typically from vitreoretinal traction.
Meaning the vitreous gel is pulling on the retina.
Exactly. A classic example is during a posterior vitreous detachment, or PVD. As the vitreous pulls away, it can tug on the retina, triggering those photoreceptors and causing the perception of light flashes. Often happens alongside the floaters from the PVD itself.
And you also mentioned inflammation or blood.
Right. Conditions like uveitis, which is inflammation inside the eye, or a vitreous hemorrhage from a ruptured retinal vessel, they literally introduce inflammatory cells or blood cells directly into the vitreous, and those cells create the flares.
Okay, let's break down the specific causes then. Starting with the purely ocular ones, what are the most common culprits we're likely to encounter?
Probably number one, the most common cause overall, especially in middle age and beyond, is posterior vitreous detachment, PVD. The mechanism is just age-related liquefaction of the vitreous gel. It shrinks, collapses, and pulls away from the retina. This process can create opacities or cause traction.
Symptoms.
Sudden floaters, often described as a cobweb or a ring, plus those photopsias we talked about, maybe some blur. Now, the key insight here is crucial. The PVD itself, the vitreous detaching, is usually benign, but the traction it creates during the detachment process, that can potentially tear the retina. So if you see a Weiss ring, that's a visible ring-shaped opacity floating around, representing where the vitreous detached from around the optic nerve, you must diligently search the peripheral retina for any associated tear. It's a sign the PVD has happened, but not necessarily that it happened without consequence.
So seeing a Weiss ring means look harder for a tear.
Absolutely. Consider it a flag to be extra vigilant with your peripheral exam.
Okay, what's next on the common list?
Then there's vitreous hemorrhage. This is simply blood getting into the vitreous cavity, usually from a ruptured retinal vessel. Common causes are things like proliferative diabetic retinopathy, retinal vein occlusions, sometimes trauma, or even a retinal tear that hits a blood vessel.
And the patient reports.
Floaters, definitely, often described as spots, clouds, or even just a diffuse haze, and blurred vision, ranging from mild to really severe, depending on how much blood there is.
And on exam.
You might see a reddish or dark haze in the vitreous. Sometimes it's so dense you can't see the fundus at all, the nugget here. Even a small bleed can cause surprisingly significant floaters, and you always need to try and find the source of that bleeding.
Makes sense. What about inflammation?
Uveitis.
Yes, uveitis, specifically intermediate or posterior uveitis, or systemic inflammatory conditions like sarcoidosis that affect the eye. The inflammation leads to inflammatory cells, like white blood cells, accumulating in the vitreous, causing vitreous haze or clumps we call snowballs.
Symptoms beyond floaters. Often blurred vision, photophobia, light sensitivity, maybe redness or pain. Signs include cells and flare in the anterior chamber, plus those vitreous cells or haze. The clinical pearl for uveitis-related floaters is that the onset might be more gradual or insidious compared to a PVD. They might be more numerous, and crucially, they're accompanied by other signs of inflammation.
Okay. And the really urgent one we keep mentioning.
The big one, retinal tears or detachment. This is where vitreoretinal traction physically tears the retina. Often this tear can bleed, adding hemorrhage to the mix.
Symptoms again?
Sudden floaters, definitely, often a shower of them. Photopsias are very common. But the most critical symptom is visual field loss, like a curtain or shadow coming across the vision.
And signs.
On dilated fundus exam, you might see the actual retinal tear, or you might see the detached retina itself looking elevated and sometimes corrugated. The absolute must-know for you, the bottom line, new floaters plus photopsias, especially with any hint of visual field loss, is a retinal emergency. Full stop, until proven otherwise.
Got it. Loud and clear. Now, what about those patients who describe sparkly or glittery floaters? That sounds different.
Ah, yes. That often points to asteroid hyalosis. The mechanism is these tiny calcium lipid complexes forming within the vitreous gel. They look like bright, sparkling crystals floating around.
So dramatic
Feels
looking.
very dramatic on exam, like stars in the night sky. But here's the fascinating part. Despite how impressive it looks, it's almost always asymptomatic. Patients rarely notice them, or if they do, they aren't usually bothered.
Uh-huh.
The key takeaway here is recognition. Recognize it, know it's benign, but also realize it can sometimes make your view of the underlying retina a bit more difficult. Don't let the sparkles distract you from doing a thorough retinal exam to rule out other causes if the patient is symptomatic.
Right. Don't assume the sparkles are the cause of the symptoms.
Exactly. What else? There are less common but still important ocular causes.
Like what?
Well, there are white dot syndromes. These are a group of inflammatory conditions affecting the choroid and retina, things like MUWDS, birdshot chorioretinopathy. They cause vitritis, meaning inflammation in the vitreous.
So symptoms overlap with uveitis.
Yes. Floaters, photopsias, blurred vision. Signs include characteristic white dots in the retina or choroid, plus the vitritis. Then infections. Things like CMV retinitis, often in immunocompromised patients, or toxoplasmosis. These cause infectious uveitis leading to vitreous cells. Symptoms again: floaters, vision loss, redness. You'll see specific retinal lesions plus vitritis. The differentiating factor often comes from the patient's history, HIV status, immunosuppression, exposure risks.
And conditions that mimic inflammation.
Right, the masquerade syndrome. A key one is vitreoretinal lymphoma. It's a tumor, but it presents with cells in the vitreous mimicking uveitis. Very tricky. Floaters and vision loss are common symptoms. Signs are vitreous cells, maybe subretinal infiltrates. The takeaway here is, if you have what looks like persistent uveitis, especially in an older patient, and it's not responding as expected to treatment, you have to consider a masquerade syndrome like lymphoma.
Okay. One more ocular category.
Just quickly, pigment dispersion syndrome or pseudoexfoliation syndrome. Here, pigment granules from the iris or flaky pseudoexfoliation material from the lens can get liberated into the anterior chamber and sometimes into the vitreous.
Causing floaters.
Yes, patients might report floaters or transient blur. Signs include pigment on the corneal endothelium, that classic Krukenberg spindle, or on the lens, and maybe elevated IOP. The relevance here isn't just the floaters, but the significant risk of developing glaucoma associated with these conditions.
Wow, okay. That's a really comprehensive list of eye-specific causes. But you hinted earlier that sometimes floaters can be a sign of something systemic going on.
Absolutely. It's crucial to remember the eye can be a window to systemic health. For instance, diabetic retinopathy.
How does that cause floaters?
Two main ways. Abnormal blood vessels can grow, neovascularization, and leak, or they can bleed directly into the vitreous, causing a vitreous hemorrhage. So symptoms are floaters, sometimes sudden and severe vision loss. Signs are the hemorrhage itself, plus other signs of diabetic retinopathy like microaneurysms or exudates. For your patient, if they have diabetes and report new floaters, diabetic retinopathy jumps way up the differential list.
Makes sense. Other systemic links.
Retinal vein occlusion. When a retinal vein gets blocked, it can cause backup pressure, leading to retinal hemorrhages, macular edema, and sometimes vitreous hemorrhage. All can cause floaters or blurred vision. You'll see those characteristic hemorrhages, maybe cotton wool spots, and macular edema on OCT. And one more to consider: embolic disease. Sometimes small emboli like cholesterol plaques from carotid arteries, called Hollenhorst plaques, can travel to the retinal arteries. Patients might experience transient spots or fleeting floaters, or even temporary vision loss, amaurosis fugax. You might actually see the embolus lodged in a vessel during the fundus exam. The insight here is critical. Floaters, in this context, could be the first warning sign of significant systemic vascular disease, like carotid artery stenosis, increasing stroke risk.
That really broadens the perspective.
Right.
So given this huge range of possibilities, from benign PVD to systemic vascular disease, how do you actually approach the workup? What are the practical steps in the clinic when a patient presents with floaters?
Right, this is where it gets really practical for day-to-day practice. It absolutely starts with a thorough history.
What are the key questions?
Focus on the onset. Was it sudden, like our case, or gradual? How many floaters? One, a few. A shower. Are there associated symptoms? Critically. Photopsias. Any vision loss, central blur, peripheral shadow. Any pain. Redness. And don't forget risk factors. Are they highly myopic? Myopia stretches the eye, thinning the retina, increasing risk of tears. Any history of eye trauma. Recent ocular surgery, like cataract surgery. Any relevant systemic history, diabetes, hypertension, inflammatory conditions, HIV.
For a resident on call, maybe getting a quick phone consult, what's the one history question you absolutely must ask?
Were there any flashes of light, and has any part of your vision gone dark or blurry like a curtain? That combination, flashes and field loss, is the highest alert.
Okay, history nailed down, then the examination. How do you prioritize?
The exam needs to be systematic but focused. Start, always, with visual acuity. Document it carefully. Any drop is significant. Then, move to the slit lamp examination. Look carefully at the anterior chamber for cells and flare signs of inflammation or uveitis. Then look behind the lens into the anterior vitreous. Can you see cells, haze, pigment, that white ring we talked about?
And the most crucial part.
Without a doubt, the dilated fundus examination. This is non-negotiable for new onset floaters, especially with flashes. You need to examine the entire retina from the optic nerve and macula right out to the far periphery, the ora serrata. This often requires scleral depression to get a good view of the peripheral retina where tears often hide. Tears, detachment, hemorrhage, signs of inflammation like vitritis or retinitis, vascular abnormalities, emboli. Everything we've discussed.
What else on the basic exam?
Check intraocular pressure, IOP. It can be low with a detachment, high with uveitis or pigment dispersion glaucoma, and perform some form of visual field testing, even if it's just confrontation fields, to screen for any peripheral defects the patient might not have noticed.
Okay. What if the basic dilated exam isn't enough? Or if, say, there's a dense vitreous hemorrhage and you just can't see the retina?
Great question. If your view is obscured, B-scan ultrasonography is your next best friend. It uses sound waves to create an image of the back of the eye. It can show you if there's a retinal detachment hiding behind the blood or vitreous opacities, tumors. It's essential when you don't have a clear view.
Any other tests?
Depending on what you suspect. Fluorescein angiography, FA, can be helpful to look for vascular leakage or ischemia, say in suspected diabetic retinopathy or vein occlusion. Optical coherence tomography, OCT, is invaluable for assessing the macula, looking for edema, subretinal fluid, vitreomacular traction, and don't forget systemic tests if the history or exam points that way. Blood glucose if you suspect diabetes, maybe an ESR, CRP, ACE level, or syphilis testing if you suspect inflammation or uveitis, HIV testing if risk factors are present.
Okay, that's a solid workup plan.
Yeah.
So bringing it all together, what does this mean for management? You've done the history, the exam, maybe some tests. How did you decide what to do? It seems entirely dependent on the cause.
Exactly right. It's absolutely cause dependent. There's no single floater treatment. For benign floaters, say, a straightforward PVD with no retinal tear or stable asteroid hyalosis, the management is primarily observation and reassurance. You educate the patient about warning signs of a tear or detachment, new flashes, increased floaters, curtain, but otherwise you let them know the floaters often settle or become less bothersome over time as the brain adapts.
But if you do find a tear,
Then it's urgent. Retinal tears need prompt treatment, usually with laser photocoagulation around the tear, to spot weld the retina down and prevent fluid getting underneath. If a retinal detachment has already occurred, that requires surgery, commonly vitrectomy, maybe a scleral buckle or pneumatic retinopexy to reattach the retina. Time is critical here to preserve vision.
and for blood in the eye, vitreous hemorrhage.
For vitreous hemorrhage, if it's mild and you're confident there's no underlying tear or detachment, maybe via B-scan, you might observe initially to see if it clears on its own. But for dense, non-clearing hemorrhage, or if it's from proliferative diabetic retinopathy, vitrectomy surgery to remove the blood is often necessary.
Inflammation or infection.
Uveitis generally requires corticosteroids, topical, injected, or systemic, to control the inflammation. Infections need specific antimicrobials, antivirals for CMV, antibiotics for toxoplasmosis, etc., often alongside steroids once the infection is under control.
And the systemic-related causes.
For diabetic retinopathy or retinal vein occlusion, management often involves anti-VEGF injections into the eye to reduce leakage and abnormal vessel growth, sometimes laser photocoagulation or vitrectomy if there is significant hemorrhage or traction. Masquerade syndromes like lymphoma are complex. Management might involve biopsy, followed by chemotherapy or radiation. And for pigment dispersion pseudoexfoliation, the main thing is monitoring closely for glaucoma and treating elevated IOP plus standard refractive correction.
That covers a huge amount. Okay, we've gone from definition to causes to workup and management. If there's one key takeaway message, one absolute high-yield pearl for our listeners, the ophthal residents, the final year MBBS students, what should it be?
Okay, the single most critical point, the thing you absolutely cannot afford to miss. Sudden onset floaters, especially when accompanied by photopsias, in any patient, but particularly those with risk factors like myopia or trauma, strongly suggest a retinal tear or detachment until proven otherwise.
So that combination is the ultimate red flag.
If that's the ultimate red flag,
Right.
You must assume it's tear or detachment and act accordingly. That means an urgent, thorough, dilated fundus examination is absolutely mandatory, same day if possible. This is how you prevent potentially irreversible vision loss.
So back to our 60-year-old patient with the shower of dots and flashes.
That patient needs to be seen now. A shower of dots, flashes, any hint of a curtain or shadow in the vision that warrants immediate same-day ophthalmology referral and examination, no question.
And if you're the first one seeing them, maybe in A&E or general practice?
Your immediate action is to facilitate that urgent ophthalmic review. If you are able to do a dilated exam, great. But the priority is getting them seen by someone who can do a definitive peripheral retinal exam, potentially with scleral depression. If the view is obscured by hemorrhage, communicating that is vital, as they'll likely need a B-scan ultrasound urgently. Remember, sudden floaters with flashes are a retinal emergency until proven otherwise. Act fast. Your timely assessment and referral can genuinely save someone's sight.
That's a powerful message to end on. Okay, that's a wrap for today's deep dive into floaters. I really hope that brought some clarity to your clinical thinking and helps you feel more confident managing these common, but sometimes critical, presentations.
Absolutely. Stay vigilant with floaters. Your careful evaluation truly makes all the difference for your patients.
Stay focused, keep learning, and we'll catch you on the next deep dive from Optic Surgeon, the Ophthalmology Podcast.